Thank you. Good morning. You're wondering why is an anesthesiologist talking about gunshot injuries and mechanism? The reason is I got tired of talking about airways. The second reason is every time a surgeon is working on a trauma patient, you also have an anesthesiologist keeping that patient alive. Otherwise it wouldn't make much sense. So airway management is just a very small part of our job, actually. Talking about firearm injuries, there were about 17,215 unintentional firearm injuries in 2008. That's for the Center of Disease Control, and only 276 deaths. So from that point of view, handguns are actually pretty safe. And if you compare that with motor vehicle accident, over 3 million, gunshot injuries shouldn't be much of a problem for us. Except people use guns to kill each other. So first, people kill themselves, and it's about 18,000 a year. And we have deaths, about 12,000 people who were assaulted with firearms. So that's about 30,000 people. And that gets pretty close to motor vehicle accident deaths, which is 39,000. Assault with firearms happened, we had in about 70,000 cases. 56,000 were injured, non-fatal, and 12,000 died. That is an interesting number because we all think if somebody gets shot by a firearm or by a handgun, they die. But if you look at those numbers, actually 6 out of 7 survive. And just a little bit more, 1 out of 7 dies. This is very interesting. So firearms, especially handguns, are actually not as deadly as we sometimes think they are. If you look at the number of guns in the US, we have about as many guns as people, statistically. It's hunting rifles, semi-automatic, shotguns, revolvers, all kind of guns. But if you look at the homicides by firearms, it's mostly done by handguns. And the reason is that handguns are easy to conceal, easy to carry, they're light, they're cheap, ammunition is cheap, and luckily I must say 76% are done by handguns. If you look at the rifles, it's only 4%. And that is a good thing because if more crime would be committed by handguns, there wouldn't be much to do for us. The wounding mechanism is direct injury, which is the primary cavity, and the indirect injury, the secondary cavity. We'll look at that later in a video. The cause of death is tissue destruction, but only in a very small cases. So the part of your body that you need to live is actually very small. And it's not the part you're thinking, it's actually in your brain. It's your brainstem. So the brainstem is the only part in your body you actually need to live, basically. So why do people die when they get shot? It's mostly because of bleeding. So tissue destruction in other parts of the body causes you to bleed, which causes you hypotension, loss of consciousness, vomiting, airway obstruction, loss of airway, but it's mostly bleeding. If we talk about rifles around the world, that's Kalashnikov, the most famous rifle. We have rifles in the neighborhood, and there, and in the families. So, very popular. There's another AK-47, right? Wrong. This is not an AK-47, this is a Sturmgewehr 44, which is the mother of all assault rifles, and it's worth about $20,000. I do not think she knows about that, because otherwise she wouldn't be using it. This is an M16. These are some rifle rounds. You see the different sizes. And the first one is the old NATO caliber, 7.62, or if you're hunting, it's 308 caliber. Then you have the modern NATO ammunition, which are 5.56 millimeter, or for hunting, .223. This is a AK-47 ammunition. This is for the AK-74. They are also smaller calibers, just to give you a difference in size. If you look at the numbers, again, this is the old military caliber, relatively heavy, large diameter. These are the new NATO ammunition, small caliber, .223, small weight. This is the Kalashnikov again. This is interesting is the speed, muscle speed, and the energy. It's very interesting for the small calibers and how they function or are supposed to function. If you look at the new modern high velocity rifle ammunition, the 5.56 millimeter, the injury mechanism is actually not the direct destruction by the bullet, but the fragmentation and jarring of the bullet. This is what happens when the bullet enters ballistic gelatin. The bullet fragmentates and causes this large cavity. This is the idea or the concept behind it. This is how it looks. Oops, try again. And you see again the cavitation on the right side. And if you look again in the beginning, you see right away how it fragmentates here. And this is how these bullets became so deadly, but only when they fragmentate. And you may have heard reports, or if you were serving in the military, what happened is small people, when they got shot with this new high-speed caliber, they may still be fighting. And the reason is that the jarring of the bullet actually happened after the bullet exited the body. And in this case, it was just a very small caliber bullet, and it did not cause much damage. Because as we talked before, you have to injure the structure to cause any significant bleeding. And because of the small caliber, this is just a 5.56 millimeter ammunition, which is a very small caliber. This is one of the reasons that the military is looking back into larger caliber ammunition. This is a direct comparison between a 5.56 and a 7.62 caliber. And the larger caliber, the weight, the diameter causes clearly more damage and more injury. This is the effect of a 7.62, and this is the same gel, and you see there's a lot more destruction than you had before with a small caliber. And just for comparison, this is a 50 caliber, and you see that the gel is pretty much gone. And this is how it looks when a human target gets struck. And this is JFK, same picture, and that's what I said before. If more people get shot with rifles, there isn't much to do for us. Luckily, most injuries happen with handguns. This is also a rifle injury, a 5.56 millimeter. This is an entrance wound, this is an exit wound. And how did it happen? With these short-barreled rifles, they're often carried way down, and they're aiming right at the knee. And this is how the bullet ended up in the tibia. And this bullet did exactly what it was designed to do. It started tumbling, and you can see it completely disintegrated the tibia. And that is the effect how these bullets work. They're relatively long. As soon as they slow down, as they hit tissue, they start tumbling, they fragment, and they cause severe injuries. But if the same bullet would have been shot through a muscle, like the biceps, it would have looked like an ice pick injury. Not much to it. But if these bullets tumble, they are devastating. This is a facial gunshot wound. You have seen that before. This patient did survive. This is the CT scan, what happened to the bones. And this is a shotgun injury, which we luckily also don't see very often. And this is an X-ray of it, with all these bullets in it. So this is pretty much, we're going to talk about rifle injuries, because again, you won't see too many, and if you see them, there's not much to do. So let's talk more about handguns. This is something we see actually quite often. As I mentioned before, 76% of all assaults are committed with handguns. This is military rifle ammunition, 7.62. To comparison, this is a 45 caliber, this is a 40, this is a 9 millimeter, this is a 22. So you see already the bullets are a little smaller and the propellant is definitely less than in a rifle. The wounding factors of the projectile are bullet size, bullet weight, bullet design, fragmentation of full metal jacket, we talk about that, the speed of the bullet, and it also depends on the patient. What tissue is damaged, how big is the patient, how deep is the penetration. There are two mechanisms of injury with handguns. The first is a crush injury, the main injury, and the second we talked before is the stretching of the tissue, which is not very significant in handgun injuries compared to rifles. And the FBI, I think, came up with that. Yep. The Wound Ballistic Workshop, when they were looking at 9mm versus 45, said that the crush mechanism, the result of the penetration and permanent cavity, is the only handgun wounding mechanism. Which that means is that with a handgun bullet, you have to destroy a vital structure, which in most cases is a blood vessel. These are the different designs, common designs, which is a hollow point and a full metal jacket. Many police officers or for self-defense actually use the hollow point ammunition. We have police officers with 9mm, 40 caliber, and sometimes 45, but it's usually the smaller calibers. The reason they use these self-defense ammunition or hollow point is the idea that these rounds expand, and this is how they look. So actually the diameter of these bullets increases when they hit the target, which makes the bullet bigger and causes more injury. So given adequate penetration, a larger diameter bullet will have an edge in wounding effectiveness because it will damage blood vessels that the smaller projectile barely missed. So the bigger the bullet, the bigger the chance that you actually hit something. Same line. To cause significant injuries to a structure within the body using a handgun, the bullet must penetrate the structure. It's very important because what happens is these are the vital structures in the body plus the liver. And as you can see, they're relatively small to hit. That's why targets changed to this design from that one. Some people use the zombie targets, also very popular. But if you look at different speed and energy, I'm just comparing different size or similar size bullets. This is a 45 caliber handgun compared to a 308 rifle. You see the speed is almost 3 times as much with the rifle, and the energy is also a lot higher. When I compare a small handgun bullet, 22mm, and the 5.56 rifle, which is again the same diameter, but look at the energy. The energy is 10 times as much in the rifle than with a handgun. The other thing we always think is that if somebody gets hit by a bullet, they fly 10 feet through the air and land on the ground and are dead. That doesn't happen either. The impact of a 9mm bullet on a body is about the same as a 10-pound weight that's dropped 0.7 inches. So if I throw it up in the air half an inch and I catch it, that's the same energy transferred by the weight than by the bullet. So a victim being shot by a 9mm bullet is not flying through the air. Okay? And to prove my point, this is a video where this gentleman on the left gets shot twice. Bang, bang, and he runs away. He did not drop, he didn't even flinch. He just got shot. And he's still running. They finish a robbery. I had to shorten the video because it was kind of getting boring. And now look at the right lower corner. There's a victim. Now he's laying down, right? Well, he gets bored too, so he gets up and he walks away. This patient got shot in the chest and the belly. I'll show you the video again. He's getting shot now. He just runs. And this is the reason, for example, why police officers shoot more than once, because they not necessarily know if they hit the first time, or the second time, or the third time, because you can't tell. And when this patient goes up, just look at his left upper back at the shoulder, you see the blood. There. And this is what you may see when you're at the scene, or you have seen it before. Your patient is sitting there and doesn't want to write with you, or they may be walking around. The reason that they sit down is usually because they are bleeding somewhere, so they become hypotensive, they get dizzy, they sit down. But somebody who gets shot twice is quite capable of doing a few things for several seconds or even minutes. They do not drop dead immediately. This is a complete misconception. And these are handguns, same ballistic gel, just show you the difference to the rifles we had before. This is a 45 caliber. Goes in, penetrates, exits, but not as impressive as the rifles. And there was another one I wanted to show you. This is a 40 caliber hollow point. No, it's not. Damn it. I think I missed that video. So this patient got shot by a 40 caliber hollow point, and you see the bullets here. So who thinks this patient is dead? Most, right? Because he should be. That's a nice tap right in the chest. This patient is not allowed to live. So, and you see how they not fragmented, but how they expanded. So now we looked at the lateral picture. And just going forwards and back, this bullet here is the one on the right. So it went through the lung, got stuck in the muscle in the back. This bullet here is that one. And if this bullet would have traveled another few millimeters, it would have hit the aortic arch and the patient would have bled to death within seconds. But the bullet did what it's supposed to do. It expanded when it hit the sternum. It barely got through the bone, and then it stopped because it slowed down. And that is a downside with this expanding ammunition. It's get bigger, but it slows down. So the penetration, the depth, is not as much as in a normal bullet. And this actually saved this patient's life. He's doing well, because the bullet again stopped a centimeter before it hits a vital structure. So no injuries, or no significant injuries. There's also the story about the magic bullet, or the miracle about entrance and exit wounds. And you may remember this, Kennedy, Connelly, and there was a rumor that there was a magic bullet which hit Kennedy in the back, exited his neck, stopped for 2 seconds, I think, and then hit Connelly from this side. Well, they still couldn't explain why the bullet stopped for 2 seconds, but what turned out is that Connelly actually was sitting more medial to the car than Kennedy. Also, both of them were turning towards the crowd for waving, and they were not sitting in a straight line. So now if you turn the bodies the right way, actually it ended up as a straight line. It was possible. So it was not a magic bullet. And the reason we have these misconceptions is because we all looked Westerns when we were younger, and we know that this is the way how you go to a gun battle, right? Upright, trench coat, and you walk like a man. Well, the reality is it's more likely that you're going into a gun battle like this. It was last year in Thailand, I think. Or like that. So if you look at the first gentleman, and let's say he gets shot in the left upper chest, 5 intercostal space, where it's going to be the exit wound. Well, it's going to be probably left scapula. And that's exactly what happens when this patient ends up in the emergency room. He's getting shot here. Everybody looks at the left upper back for the exit wound, naturally. But what if this gentleman gets shot in the left upper chest? Well, his exit wound may be in the left buttock and not left upper chest. So you really can't tell where your exit wound is. Or if he's leaning over a little bit further and he's getting hit in the left chest, this bullet actually may end up in his pelvis, but will be too weak to exit, and he will have no exit wound whatsoever. Also, if he gets shot with a handgun, he may turn around and run away. And then he gets shot again in the back. So now you're having 2 entrance wounds, and you may think one is an entrance, one is an exit wound. So it's always confusing. And I didn't find it too useful with trying to figure out what's an entrance and exit wound. If one wound is definitely bigger than the other, it's likely an exit wound. But with handguns, for example, more likely than not, you will not have an exit wound, because they are simply too weak to penetrate. And this is a nice example. This patient did get hit in the left upper chest, second rib on the left side. Do you see the bullet? No. Any guess where the exit wound is? So we were all looking, of course, in the left upper back. There was no exit wound. We scanned the whole body. There was no exit wound. And then we found a bulging down here in his right groin. So we did another x-ray, which unfortunately I don't have, but the bullet was lying in the right groin under the skin. What happened is this patient was in a similar position like this one here. So he was leaning forward, he got hit in the chest, it broke the second rib, and the bullet just traveled under the skin all the way down to his belly. No exit wound whatsoever, and also no severe injury. And one of the reasons is that skin is very resistant. So experiments have shown that skin has the same resistance as 4 inches of muscle tissue. And we actually see that quite often with handguns. They do have an entrance wound, they cause some damage, and then they get stuck, either in the muscle or under the skin. So they're often not fast enough to exit again. And then you see these little bumps somewhere on the body, that's a bullet. It does not happen with rifles, but it does happen with handguns quite often. This is a trauma patient who was shot or got shot himself with a .357 Magnum, which is a very powerful handgun. He was brought to Harborview, was hypotensive, largely unresponsive in the field, and intubated. This is very important. You were at the scene at 23:24. The patient was in the ED at 23:50. I was there too. 9 minutes later, the patient was in the operating room. Sorry, 11 minutes later. 9 minutes later, we did the incision. This is the anesthesia record. And if you look at these upper numbers, this may all look very familiar to you. This is fentanyl. This is midazolam. I did the whole anesthesia just with midazolam. I used rocuronium for muscle relaxation. You got some antibiotic. We gave plasma-light, not too much. This is the fresh frozen plasma here and the blood transfusions there. And if you look at the record down here, those are the heart rates and the blood pressure. And as you see, my blood pressures, or not mine, but the patients, are not very high actually. So the mean blood pressure is hovering around the 60s here. When I gave some epi, it goes a little bit higher. The systolic blood pressures are in the 80s. They're not even close to the magic number of 90, unless at the end of the case. This is what's called permissive hypotension, which actually works very well in bleeding, hemorrhaging trauma patients. And this is something I do in the operating room quite regularly. This is an entrance wound. There was no exit wound. This is hemostasis, what happens in the ER quite often, where the surgeons do a thoracotomy and put an aortic cross clamp on. This clamp is sitting on the aorta and basically reduces the circulation to the upper body, brain, heart, lungs, and arms. And this is a life-saving procedure which is done within minutes in the ED. And after that, the patient goes down to the operating room. So now we have time to replace fluid, and the surgeons also have time to operate. So I'm going to show a video that's a little bloody, so if you don't feel well, you may not want to look at this. This is also expiratory laparotomy, the first few seconds of the case. This is the area to look at. So this patient is massively bleeding into his belly. We are just a minute into the case. The surgeon started operating. And you see all the blood coming out here. And now I'm getting dizzy. So that's how it looks in the operating room. And this is what I wanted to show you, because this is the patient's primary problem. There's no magic how bullets kill. Bullets kill by damaging vasculature, and patients bleed to death. And the only thing that helps a patient is to have surgery relatively fast. They don't need any other treatment, they need surgery. Somebody has to plug those holes as fast as possible. The way I treat these patients, this patient had a blood loss of over 8 liters. I gave 5 liters of crystalloids total, and that included what you gave him. 16 units of red blood cells, 14 of FFP, 2 platelets, and 2 units cryoprecipitate. And the idea behind this concept is that if a patient is bleeding and losing blood, you need to replace blood. You cannot just replace water. It doesn't work. This is a strategy that has been known for a very, very long time. Again, it's called hypotensive resuscitation. It's known that it reduces transfusion requirements and it increases a survival rate. But over the last years, anesthesia very often gave way too much crystalloids. And the reason is also we all follow ATLS guidelines, which I strongly believe in, but the problem is if you follow ATLS, 2 liters of crystalloids. The ED follows ATLS, there goes another 2 liters. And the patient comes to me in the OR, and the first thing I hang is some more crystalloids. So what I do is I dilute the patient further and further and further. And that makes no sense. So crystalloids are very good to bridge some time, but they have to be limited. So the moment the patient comes to me in the operating room, I start giving blood products. And since the patient is not just losing red blood cells, I'm also giving FFP, which contains the coagulation factors. Because otherwise, if you replace water and red blood cells, the patient becomes coagulopathic and the bleeding gets worse. Also, when I'm in the operating room and the patient does not have a traumatic brain injury, I aim for lower blood pressure. Because it doesn't make any sense to have a patient with a blood pressure of 120 over 80 in the operating room and they are actively bleeding. They're just bleeding more and more. And the patient I demonstrated you before, he was hypotensive for almost 2 hours, woke up the next morning and was communicating with us at 12. So he was fully awake after going through this procedure just, 10 hours earlier. But the key to success in these patients is actually this, and that means not wasting any time. So you brought this patient to Harborview really quickly. We looked at the patient, he got his cross clamp, and he went straight down. Those patients don't need an emergency room, they need an operating room. The emergency room is just for a very quick assessment and then further down to the operating room. And this is what saves the patient's life. And we know from studies that the longer you wait with surgery in those patients, the higher the mortality. I think the mortality increases about 0.3% per minute that you waste in a bleeding abdomen. About fluid management, things are going to change in the future. And I say that because in medicine everything takes about 10 years. We do have the tactical combat casualty care, which came up in about 2001. And one of the ideas was to reduce or limit the amount of crystalloids before surgery, which affects you. And the current recommendation here is about 250 ml. The ATLS guidelines are still a little bit higher, which I think is going to change very soon because there was a revision of these technical guidelines just this last year actually. And the discussion was brought up in a special commentary in the Journal of Trauma, which is read by all surgeons. So I think that we're going to see some influence from that into the civilian trauma care because ATLS will likely also change their recommendations in the future. So one of the findings was that the primary recommendation was that fluid resuscitation should be instituted for a systolic blood pressure of less than 80, 85. So we're going away from the magic 90. A falling blood pressure or decreasing ability to mentate, which is also a sign of hypotension in patients without evidence of head injury. Again, head injury, completely different topic. No fluids should be instituted in the presence of a strong radial pulse. Again, this is not for you yet, okay? But I hope to see this in a few years. But this is a tactical casualty care. So as long as they can feel a radial pulse, they don't give crystalloids. With the whole concept again is if you do have a strong or palpable radial pulse, you have enough perfusion in your brain. That's all you need. And fluid should be initiated for weak or absent radial pulse or decreasing level of consciousness in the absence of head injury. For the further treatment in the operating room, what we do already is limit the use of crystalloids, which I described to you earlier in that anesthesia record, and to go with a blood transfusion of reconstructed whole blood, which we don't have. But if I use 1 unit of FFP and 1 unit of red blood, I'm basically mixing me some whole blood back together. And after 6 to 8 units, I add platelets. This is a 1-to-1-to-1 transfusion ratio. These findings are all based on military experience, but as we know, pretty much all military experience sooner or later reaches civilian trauma care. Because it doesn't matter if you get shot in a military conflict with a handgun or if you get shot in Seattle. There are some differences, like our rescue times or on-scene times are smaller, shorter, nobody is shooting at us, but it's still the same injury mechanism. So I would predict that we're going to see some changes in pre-hospital fluid management over the next years coming up. Again, right now not, I just wanted to make a prediction. So the summary from this talk is most people get shot with handguns, not with rifles. Handguns are not nearly as deadly as most of us think. So 6 out of 7 people actually survive their injuries. It is impossible to assess the injury severity at the scene unless you have a real tissue destruction. But remember the patient I showed you before who has these 2 bullet holes right in his chest? You can't just give up and say he's dead, because those bullets didn't penetrate deep enough. This patient is walking around. So be careful as how do you assess those patients on the scene. There are often no exit wounds. Handguns have a very low penetration depth. Be concerned about airways. So please manage the airway. That's the only thing I say about airways. The most likely death is due to hemorrhage. And that means the faster you are in the operating room with that patient, the better. Which still means I appreciate 2 big IVs. Okay? Because you may still have enough blood pressure and blood flow in the field to get a 14 gauge or 16 gauge in. At the time the patient arrives in the operating room 20 minutes later, that may not be the case. So some large bore IVs are definitely appreciated, but otherwise quick transport is key. And expect some changes to fluid resuscitation in the near future. Any questions?